All right, guys. Hey, so um, we went over this on Monday. Tried to record it, but for some reason it didn't come through. So I am re-recording it now. So this is a re-recording of the mechanisms of neurotrauma lecture from Monday. So we'll go through this. That way we have kind of a lecture version of this as well for you guys to refer back to as needed. All right, friends. So you remember we talked about this. We know, right, that every nerve, every peripheral nerve has a nerve that consists of fascicles, right? And ultimately, every fascicle, so a nerve is made up of fascicles, every fascicle is filled with neurons. So, one of the things that essentially differentiates peripheral nerves really so much from the CNS, as Bennett mentioned on Monday, right, is that peripheral nerves are essentially covered, not necessarily in dura, right, but they are covered in essentially uh, these layers of essentially basically myelin, right, and fascia, right? And we refer to these things first of all as the uh, obviously the uh, epineurum, right? So the outermost layer being the epineurum, right? And um, ultimately, the epineurum is essentially kind of contiguous with fascia, right? Uh, Around really near joints and muscles. This is something that we'll talk about a little later. This is also where we see um, you know, uh, as these nerves pass through joints, it's because of the epineurum that sometimes we have a propensity to develop these peripheral nerve compression syndromes like carpal tunnel and others, right? Um, at the level of a joint. So ultimately, we'll see, um, you know, either thickness of the epineurum and or compression via like maybe a thickened ligament or bone or some sort of other foreign body, right? And as we mentioned Monday, and we'll talk a little bit more about this, spinal nerves and nerve roots don't actually have an epineurial covering, right? They're actually made up of these kind of differing layers of fascia, essentially that are contiguous and kind of arise from the dura themselves. Okay. Um, what about the other two layers, friends? What about the and then the sorry if I can talk. Okay, what about the perineurium and the endoneurium? Okay, so the perineurium surrounds the fascicle. All right. So if you remember, one thing that we said about the perineurium is the fact that the perineurium is actually the strongest of the three uh, coverings, right? Because precisely because it has the ability to take on fluid, right? And as it takes on fluid, it actually develops more tensile strength, right? There is actually uh, a a baseline pressure of about 1.5 millimeters of mercury, right? That's kind of basically normal, right? So the problem being, as we'll talk about in a second, though, is that as the endoneurium takes on more and more fluid, uh, there are times when it can actually compress the local microvasculature around the nerve and or potentially even rupture, right? So the endoneurium itself, right? This is actually uh, the essentially the covering that surrounds the neuron, right, itself, right? So the endoneurium is essentially made up of collagen fibers, right, and fibroblasts. So collagen, although tough, right, at least here, is still very, very fragile, right? So um, this is, as we'll see in a little bit, excuse me, prolonged tension across the neuron can actually cause not only stretching and breaking of the endoneurium and even of maybe even the fascicle, but also right, can cause um, essentially also a rupture uh, of the endoneurium and those collagen fibers, right? So what about the microvasculature though? What about the blood flow? So uh, ultimately, vascular supply to the nerve, right, comes from those larger vessels, right, and essentially uh, gives rise to a structure that's called the vasa nervorum, right? The vasa nervorum is a vessel at the level of the neuron that runs longitudinally along the neuron, right? Um, and as it runs along the side of the neuron, it actually anastomoses or connects, right, with the microvasculature, obviously inside of the vesicle, right, um, and provides the neuron with its blood supply. So, as we talked about um, in the epineurum, right, where I'm sorry, in the perineurum, forgive me, where we have the propensity for pressure to increase, right, and the ability to essentially collect fluid. As that fluid pressure increases, it can actually kind of place pressure on the vasculature, right, and impede the blood supply. Um, of the nerve at that location. Now, the one thing anatomically that's actually really really useful about the way that about this model and the way that it's laid out is the fact that even if you have compression at one end of the nerve, because that vasa nervorum and that the vasculature runs essentially in parallel, right, to the nerve, the rest of the nerve is actually still going to receive blood supply despite compression in one area, right? Um, Maybe with the exception of like gross trauma or gross injury, right? But ultimately, anatomically, it's a very efficient system for continued delivery of blood and nutrients to the nerve itself. All right, we remember this, and we talked about this on Monday. That ultimately, we have dura, right? The dura themselves are essentially what cover the brain and spinal cord, and we have three layers, right? We have the outer layer, which is the dura mater. We have the middle layer, right, which is the arachnoid mater, and then we have the innermost layer, which directly overlies the brain and spinal cord tissue, and that, friends, is the pia mater. Now, we also talked a little bit about the anatomy of the spinal cord, right? So the spinal cord essentially ends at what we call the phylum terminale, right? And ultimately, from essentially L2 below, we have this group of these nerve roots, right? And these nerve roots, all of them together, are essentially referred to as the cauda equina. The cauda equina, right, and/or horsetail in Latin, right, is essentially the group of lumbar nerves that we're going to learn about in a little bit more depth when we talk about the lower back. But there is a very specific syndrome that can develop called cauda equina syndrome, where patients can lose bowel and bladder function, right? Potentially even, uh, you know, experience a lot of numbness in the thighs as well, right? And that can be essentially a consequence of compression uh, of that cauda equina at more than one level. And so you can actually get some fairly serious symptoms. And cauda equina syndrome, as we'll learn later, is a medical emergency. Okay, so we did say though earlier that nerve roots essentially have kind of a different anatomy when it comes to what they're covered with, right? Nerve roots essentially are covered by spinal root sheath, right? Um, as opposed to our peripheral nerves being covered with endoneurium, right? So the vast majority of our injuries, because of the irregularity of the covering around the nerve root, are going to be more predisposed to injury. So, as we talked about, right, we know that with our brachioplexispathies, our stingers, burners, right, those are generally due to either stretch or compression of the nerve root itself, right. Um, as we'll see in a minute, an example of a traction injury, right, and that forceful lateral flexion of the cervical spine. So the other thing, though, and we talked about this in our neurotrauma lecture on Tuesday or Wednesday, I think it was Wednesday, that because the dura are essentially, covering the brain, there's not a lot of space, right? Fluid collecting under the dura can place pressure the on the brain and neurological tissue, brain spinal cord, right? Um, without a way for that to essentially uh, escape, right? And so people can develop very acutely changing neurological symptoms in the event of a subdural bleed because the pressure just continues to increase and the fluid surrounds the brain and continues to essentially go higher and higher, right, and it can eventually lead to death if untreated. Okay, So traction injuries, if we remember these, right? So here's an example, right? We just talked about that, where essentially we have that rapid lateral flexion of the neck, right, which causes that rapid stretching of the brachial plexus of those peripheral nerves, right? Um, and so ultimately, we see this a lot in, with the brachial plexus. But another common example too that we may have touched on in Tech One a year ago was damage to the peroneal nerve at the outside of the lower leg with multi-ligament knee injuries, right? That can sometimes cause a phenomenon called drop foot, okay, due to a localized injury of the peripheral nerve. Okay, the one thing that we don't really think about so much, but this is actually very, very common, kind of a classic definition of a tension injury. Uh, Traction injuries also actually can happen rather frequently during childbirth, right? So oftentimes, depending on the position of the baby inside of the birth canal, right? Whether they're breached or they're laying on their side, right? Um, Oftentimes, right, the head can actually become compressed under the pubic bone, and as the baby tries to pass through the vaginal opening, right, the brachial plexus is essentially tractioned by the pubic bone, causing essentially a traction injury of the plexus, with you know. Obviously, functional difficulties for the child later on, sensory and motor dysfunction, of that brachial plexus, uh, you know, in in early childhood. Um, there's actually a maneuver that OBGYNs actually perform, where they essentially dislocate the clavicle to be able to compress the pectoral girdle, um, and that actually allows the baby to pass through the vaginal opening um, without undue traction on the brachial plexus. Okay, compression injuries, right? So compression injury is essentially uh, they can be traumatic, but that's excuse me, that's not so common, right? So most of our compression injuries are going to be caused by what we call space occupying lesions, right? That can be blood. In this example, we see a herniated disc, and we can see that herniated disc is essentially it's broken through the outer ring of the disc called the annulus fibrosus, right? And the nucleus pulposus, so the inner portion of that disc, is touching the nerve, right? Well, here's the thing, right? When something touches a nerve itself is actually still a very very pliable structure, in the sense that uh, a nerve will actually deform under pressure. So we can see the picture at the bottom, right, where we see the nerve itself. So the green circle is essentially a normal diameter of the nerve, but if we apply a compressive force, right, that nerve actually will actually go ahead and compress down and kind of look a little bit more like almost kind of like an oval. Now, here's the thing. A nerve is not an elastic structure, so it will not regain its original shape the second that the load is essentially released, right? So, definitely possible to see things like um, sensory changes, maybe even some weakness, right? As that even after that, space occupying lesion or that offending lesion is removed. So we saw this a lot with people after hip and knee replacement. For example, with hip replacement, people complained of essentially a lot of numbness along the lateral aspect of the hip. In part, and in part that was due to the incision at the lateral aspect of the hip. But we also placed retractors at the front of the hip and had to basically pull apart hard and hold, and that actually placed pressure on nerves, right? That's what we had to do to be able to access the hip, right, to be able to perform the surgery. But ultimately, people would come in with continued numbness, tingling, that would eventually actually resolve, right? Maybe not entirely, but vast majority of cases, it would get much, much better over the course of weeks, right? Okay, so nerve injury. Okay, obviously, you guys remember this from Tech One, or I'm sorry, from Tech Two, how we essentially tend to characterize nerve injury severity three ways, right? It's neuropraxia being the least severe, right? And so that's going to be obviously compression or traction of the plexus, with neurological symptoms that typically resolve in as little as a few hours, right, to days to months. So these symptoms typically go away. Okay, axonmesis. Okay, this is more severe. This is essentially partial injury to the axon itself, right? And that results with some lasting neurological deficit in the upper extremity. So people that have axonmesis will have continued sensory and potentially continued motor deficits, even after a period of months, right? And then we have neuromesis. Neuromesis essentially involves the nerve root being torn away, excuse me, or avulsed, right, from the spinal cord. And that neuromesis can actually result in permanent neurological deficit, obviously permanent sensory and or motor changes. Okay. So what exactly happens though? What happened? Oh, sorry, I got ahead of myself. Also, one thing we want to keep in mind is that there can be chemical or inflammatory injury to nerves, right? This is most commonly seen in diabetes. People that have diabetes, right? They oftentimes will suffer from a condition known as diabetic peripheral neuropathy. Right now, the way that diabetic peripheral neuropathy, or DPN as it's abbreviated, causes damage to nerves is that elevated glucose in the bloodstream actually increases the acidity, lowers the pH, and increases the acidity in the bloodstream, right? And actually causes destruction of the Schwann cells and the myelin sheaths, right? And so, if we remember, right, our sensory nerves generally are A alpha, A delta fibers, right? Um, that if we destroy the myelin sheaths on those nerve fibers, we are not going to be able to essentially regulate sensation in a normal manner. Now, people that are, often people with diabetes, or people that are paralyzed, right, um, will often struggle with pressure sores, bed sores on like the buttock, lower back, if they're bedridden, as we can see in the picture down here below, because of the inability to feel on the sole of the feet. Oftentimes, people with diabetes will develop um, essentially diabetic ulcers on the feet and toes, right? I did a little bit of work in the podiatry clinic at TRIA, saw a few of these, and these are zero fun. They're horrible for people that deal with these. Generally speaking, the labs come in every couple of weeks for routine wound care, uh, to be able to essentially track uh, these lesions, because they can become infected and people can lose toes and feet, and even limbs, right? So diabetes is zero fun. Not has no mercy on your nervous system. Okay. So what happens though when a nerve is injured? And even severely injured, right? So after nerve injury, the nerve undergoes a process known as Wallerian degeneration. So Wallerian degeneration is essentially a gradual process where the nerve itself actually breaks down, and you know uh, the white blood cells, particularly neutrophils and macrophages, come in and phagocytose and or eat up, right, that Schwann cell debris and the remaining nerve tissue. So the nerve actually is completely and totally, the nerve dies completely and is essentially phagocytosed or digested by the immune system, right? Now, it is not uncommon, right? Nerves can regenerate, but here's the thing. Okay, regeneration of nerves is an extremely slow process, generally about a millimeter a day, right? So the average length of the average nerve is about 800 millimeters. So if you think, right, if someone has, a nerve that regenerates, it can take 2+ years potentially for a nerve to regenerate, and be normal, right? And so there's also other complications in the sense that sometimes that nerve can innervate, as it regenerates, can actually innervate the wrong structure, right? And so people can still struggle with lasting sensory and motor changes, and maybe even some residual weakness, right? So yeah, so that's Wallerian degeneration. So really, really, really complex process, but that is what happens to a nerve after injury. So all right, guys, that's it for this one. So that's a re-recording of this lecture. So I'm gonna go ahead and stop here, but um, I will put this on Moodle. Okay, once it comes through. Thanks, guys. Hope you're staying warm and safe.